Hello, my name is Dr. Suzanne Turner. I'm from Atlanta, Georgia, and I have a cellular medicine and performance practice in Atlanta, Georgia. I'm going to be talking to you today about longevity and senescence solutions. I have been on the faculty at Emory and of IPS, A4M, Occam, BioT, and SSRP. Today we're going to talk about how does the cell decide to die, what do sirtuins and NAD have to do with it, what is senescence, and what are my treatment options for longevity. My disclaimer. First, a bit of biochemistry. So many of you probably have seen this before. This is the cell cycle pathway. Your cells have a choice of which substrate to use. I would put over to the right of this or over here, as you see in the in this category to the left of acetyl-CoA, following the red arrow, beta-hydroxybutyric acid, where these are the way that the cell uses energy and its various substrates to produce ATP, NAD, etc. The cell has a choice. An efficient cell has metabolic flexibility. There is plenty of NAD plus and ATP for energy. There are few reactive oxygen species and plenty of antioxidants. I talk about with my patients the reactive oxygen species. They know about ozone being O3 and oxygen that we breathe in the air being O2, and then our reactive oxygen species are what are produced by our mitochondria, and that's O1, and they run around and can damage proteins and DNA in their pathway, injuring cells. At some point, too much reactive oxygen species causes a problem, but a metabolically flexible cell has few reactive oxygen species, although they have a few, and plenty of antioxidants to manage them. This efficient cell can easily shift substrates among glucose, fat, and protein depending on the demands and in the environment of the cell. A stressed cell, however, has excess glucose or lipid, infection, trauma, ionizing radiation. These are all stressors for the cell and are handled via various pathways, including the inflammasome. In the face of stress, the intelligent cell has a choice. It can either go by autophagy, which is a rest and repair phase. This autophagy is so important in many of our neurodegenerative disease patients. In order to allow the cell to sort of take the trash out, we use the lysosomes and autophagosomes and our immune system to remove parts of the cell that are damaged and allow the cell to restart from a clean slate. A second choice is apoptosis, which is a programmed cell death. I liken this to a house that you've decided you're going to pack up and move. Fermentation is the production of ATP from glucose in the absence of oxygen. So in yeast, this makes alcohol, but in our cells, it is a response to the oxidative stress situation. If you've read any of the articles that have come out recently about the intestinal, the colonocyte function in the face of decreased oxygen and how this contributes to the ongoing intestinal distress that occurs, and that fixing this hypoxic state of the lumen of the colon can be super helpful in the regenerative ability of those cells. But any cell that's undergoing this stress response will begin to increase its oxidative stress and the production of pro-inflammatory signals. Muscle tissue uses fermentation and makes lactic acid. Colon cells, again, affect healthy cells, and it also affects the bacterial species in the lumen. This is usually the contributing factor to our dysbiosis. This process only produces 2 NAD and 2 net ATP, but it's a quick and easy process for a stressed cell to manage. And here's an example of this occurring, 2 NAD and 2 ATP, as I mentioned. Beta oxidation is, of course, our favorite choice. This also occurs in the mitochondria, is stimulated by epinephrine and ACTH. And it's a situation where fatty acids are broken into 2 carbon units. Those 2 carbon units then can enter the Krebs cycle. So if you imagine a long fatty acid chain, each of those pieces can be broken down. Many fatty acids can be used to make up to 100 ATP, over 100 ATP in some situations. This all depends on the metabolic state of the cell, whether the cell can go through this cycle. And as you see above, the glucose produces, with oxygen, produces between 36 and 38 ATP. I've seen as low as 30, depending on the how you're counting that production and the usage in order to get the glucose into the cell. And then palmitate, which is a fatty acid, can produce 129 molecules of ATP in its use, as you see in this diagram. We look, as we're talking about sensing energy and energy, how does the cell sense energy, and how does it make decisions based on those energetics in the cell? And we look at this mTOR AMPK balance as a way to, the cell's way to determine what its next step, how does it choose where its next step is. And so AMPK is this fuel sensing enzyme. It's found everywhere, and it's regulated by the ratio of AMP to ATP, as well as NAD to NADH. It regulates many processes, anabolic and catabolic processes, as well as glucose uptake and fatty acid oxidation, as it's also involved in mitochondrial biogenesis by its association with PGC1 alpha, angiogenesis, and it's regulated by calorie restriction. So I like to think of AMPK as the sensor that notices when the cell is under stress and needs more energy, and begins to upregulate its production of mitochondria so that there are more energy generating factors present. This is involved in stimulation of liver fatty acid oxidation, ketogenesis. AMPK is involved in ketogenesis. It's part of the reason why the ketogenic diet is effective. It's involved in the stimulation of skeletal muscle fatty acid oxidation and glucose uptake. So this is going on during exercise, and it's required for the upregulation, as I mentioned, with PGC1 alpha and mitochondria. mTOR is the balancer of AMPK, and it is the nutrient and energy sensor. It also senses the redox state of the cell, and it's involved in protein synthesis. The cell's less likely to do much protein synthesis if it's under a nutrient depleted state. And so this is turned on in a insulin, glucose, energy replete state. So the decrease in mTOR activity is associated with increase in lifespan. And it's important in early life as infants are growing and changing and developing. We know that restriction of calories and methionine act by lowering this mTOR inactivation, and that overactivation in mTOR is involved in signaling development of Alzheimer's disease. This inhibition of mTOR can activate autophagy, and that's one of the reasons, as you'll see later, that we use medications or therapies like rapamycin to treat patients. This is very important in our bodybuilders and weightlifters because it is how we develop muscle in the body, is with mTOR. So it's important that in a different cell, in a different tissue, we may see an imbalance of mTOR. And this is the process, as you can see, with glucose and energy coming in. AMPK is over to the left in gray, and then as AMP goes on, it blocks the upregulation or the function of mTOR. AMPK is involved in this PGC1 alpha functioning as well, and so we're hoping that we can increase our mitochondrial biogenesis, as you see over to the right, and then lipid synthesis through PPAR gamma. This is a complicated slide, but one of my favorites that I like to refer to as I'm learning how to understand the complex interplay of these chemical synthesizers and sensors and signals. The cell continues to decline in its efficiency. As it continues to decline, the brain and intestinal cells decrease their ability to make neurotransmitters, because in order to make neurotransmitters, they all need NAD+. So your NAD+ is depleted as the energy sensing goes down. This means that the pancreas decreases its ability to, or it limits the serotonin effect of hypoglycemia on the pancreas. This oxidative stress that continues to increase in reactive oxygen species will begin to regulate gene transcription and acetylate histone, the senescent cells. What is senescence? This is an attempt at the cell to prevent propagation of damaged or diseased cells. Remember, senescence is involved in acute form in the formation of things like fingers in infants. We like senescence to occur between the fingers so to get rid of the webbing. But as we age, and also at the front line of a scar, that's where if you have trauma to a body part, senescence begins to occur at the front line. So we like senescence to a small degree, but an overabundance of senescence is associated with age and age-related disease. It is triggered by persistent oxidative stress, high reactive oxygen species, an imbalance of reactive oxygen species to antioxidants. It can be triggered by chemotherapy or radiation, impaired autophagy for any reason, including the use of hydroxychloroquine, and other autophagy impairing therapies. Mitochondrial dysfunction can also trigger this senescent state. These triggers activate the DNA damage response, and this begins to phosphorylate and activate p53, which initiates the cascade of chemical signals in the nucleus to begin this senescent phenotype. This is a Jekyll and Hyde situation with a cell where, under different circumstances before this persistent stressor, it could express apoptotic genes or autophagy, but now the cell is unable to do that and begins to secrete this metabolically active senescence-associated secretory phenotype that is unique to our senescent cells. Again, permanent cell cycle arrest, this unique pattern of pro-inflammatory chemicals, cytokines, metalloproteinases that are part of the senescence phenotype. It is dependent on mTOR and nuclear factor kappa beta being translocated into the nucleus to stimulate the unique genetic sequences. It is resistant to apoptotic cellular death, and it shifts away. These very stressed cells shift away from oxidative phosphorylation to very inefficient but quick glycolysis, which is use of glucose without oxygen. Mitophagy is impaired, and you begin to accumulate these dysfunctional mitochondria, increasing the number of reactive oxygen species and increasing the pro-inflammatory cascade. These cells are unique in that they are large, flat, and irregular in shape because of the cytoskeletal dysfunction that also occurs. They have an increased unfolded protein response, so these poorly transcribed and poorly chaperoned proteins, which are unable to be used, begin to junk up the endoplasmic reticulum and are unable to be translocated out of the cell by lysosomes. This excessive lysosomal activity produces beta-galactosidase. This is one of the markers we can use to determine the degree of senescence in a tissue, is the production of beta-galactosidase, although it is also produced in other situations of excessive lysosomal activity. This beta-galactosidase has paracrine effects on other cells. This is a cellular program, and it induces a stable growth arrest. So the cell is in a permanent state of growth arrest, and yet it is metabolically active, using glycolysis specifically, and these distinct inflammatory markers and signaling cytokines that affect cells around them. The stem cell exhaustion can occur with age, and their capacity for renewal declines. This is correlated with the increased number of senescent cells. So we know that patients have a difficulty, as we age, we have a difficult time collecting good numbers of stem cells, and part of this is related to the increase in again, a cartoon of the oxidative stress in mesenchymal stem cells and how a healthy cell has a balanced reactive oxygen species to antioxidant load. This unhealthy cell or senescent cell to the right actually has increased reactive oxygen species, decrease in SIRT1 in NRF2 or production of antioxidants, a decrease in the antioxidant gene expression, and then this P53 allowing for proliferation and survival in these cells that are senescent. And again, the senescent-associated secretory phenotype, as you can imagine, is associated with development of cancer, or can be. All of these disease states have been associated with the development of senescence, and so glaucoma, idiopathic pulmonary fibrosis, liver cirrhosis, there's more every day being described. And we know that elimination of senescent cells reduces inflammation across all tissues, pancreas, brain, cardiac, endothelium. So sirtuins, these are signaling proteins that regulate more than 40 protein targets through its deacetylase activity. That deacetylase does require NAD as a cofactor, and sirtuins sense the presence of NAD as an indicator of cellular health. The sirtuins are involved in that regulation of mitochondrial biogenesis, and because of its ability to deacetylate PGC1 alpha with NAD+. Sirtuins are involved in transcription factors, apoptosis, stress resistance, energy efficiency, and again, require NAD as a cofactor. Here's a diagram of the things that SIRT1 blocks and that how it's involved in uncoupling protein 2, involved in insulin signaling, involved in PGC1 alpha, increasing fatty acid oxidation, and glucose metabolism in the liver. Our immune system also ages. We can't forget about, I have a tendency to think about the tissue itself, like a liver or a spleen or a heart muscle, but we have to remember that our immune system is also going through these various stages of cellular efficiency. And so we look at the innate immune system, which is dendritic cells, things like monocytes, complement and natural killer cells. And then we look at the second stage after infection, which is involved in T lymphocytes and B lymphocytes in the production of antibodies. There is, of course, some memory that occurs in the T cell function also. And immunosenescence is a specific pattern that we see in patients with the immune system with thymic involution that occurs with age. We see an increased number of natural killer cells, but a decrease in their ability to actually work as cell-killing cells. We see a dysregulation of toll-like receptors, an increase as cells begin to be experiencing more oxidative stress, that they increase their stimulation of the inflammasome. We see macrophages and dendritic cells decrease in their ability to phagocytize invaders or even to participate in autophagy. And the superoxide production goes down in neutrophils and macrophages. We see the ability of these cells to travel decrease, and that their ability to present antigens also decreases. Our thymus gland will be gradually replaced with fat, and the thymic fat fraction is one of the markers we use for aging and disease. So what can we do about all of this? We know that calorie restriction is one of our main methods of handling this, and that's involved in NAD plus signaling to SIRT1 genes and in the histone deacetylase that occurs with SIRT activation. This also occurs with the production of ketones in calorie restriction, and we know that a decrease in calories of 10 to 40% can increase lifespan and health span. And this is specifically mediated by NAD sensing by SIRT1. We know that in obesity, that calorie restriction increases these anti-inflammatory adipokines, and so this is the downside. If your calorie restriction too much, you do have an increased susceptibility to infection. Of course, homeostasis is in the middle. Metabolic homeostasis is in a lean, healthy cell. But in an obese cell, we begin to see conversion of these macrophages from M2 to M1, which is this producing these inflammatory cells. We see an increase in the pro-inflammatory adipokine production, and we see the production of these various diseases associated with the inflammatory processes of obesity, which is atherosclerosis, type 2 diabetes, fatty liver disease, osteoarthritis, even asthma has been associated with this obesity inflammation. And this seems to occur around a BMI of 30, somewhere in this range. Calorie restriction, as I mentioned, represses these inflammatory chemicals, and by SIRT1 it inhibits apoptotic cell death. It represses the mitochondrial electron leak, which increases the efficiency of the cell. But unfortunately, calorie restriction appears to be of little benefit when started in older age, particularly in mice. Exercise in this mouse model, it directly activates autophagy in the lysosome system by upregulating AMPK and SIRT1, as we mentioned before. And then lactate, which is released during exercise, induces increased BDNF expression. BDNF is one of the neurotrophic factors. It is associated with improved spatial learning and memory retention. And it's dependent on the activation of the SIRT1 deacetylase associated with PGC1 alpha, increased efficiency of cells, increased production of mitochondria. And this AMP activation associated with after an hour of 75% VO2 max has been associated with this SIRT1 deacetylase activation. Ketone esters like beta hydroxybutyrate are 3 and 4 carbon end products of fatty acid metabolism. These are naturally produced by the liver under conditions of prolonged dietary carbohydrate restriction and fasting, so calorie restriction in general. We know that this decreases the circulating glucose and insulin, leading to decreased insulin and IGF-1 signaling. This will inhibit the histone deacetylase that repress transcription of FOXO3A, allowing for transcription of these longevity genes such as NRF2. It rebalances NADPH, increasing our ability to produce antioxidants and improving cellular oxidative stress, allowing the cells to revert away from senescence and toward autophagy. And in brain injury, ketones have been shown to be mitoprotective, decreasing cellular oxidative stress, as I mentioned before. This can suppress this inflammatory response and increase the production of BDNF, as I mentioned, that may initiate long-term repair. It does actively inhibit the activation of this NLRP3 inflammasome, which we know is associated with increasing senescence and pyroptosis, which is associated with autoimmune disease. And then we know that it acts as a direct histone deacetylase inhibitor, which alters gene expression and increases BDNF. And we believe this can be associated with improvements in hypoxic brain injury. As a note about ketones and viruses, this article just came out last month, and the suggestion is that a moderately high-fat diet together with exogenous ketone supplementation at the first signs of a respiratory distress should increase mitochondrial metabolism by bypassing the block at the pyruvate dehydrogenase complex. And beta hydroxybutyrate mediated restoration of the NADPH to NADP and the redox state, the reactive oxygen species to antioxidant state, should improve this reactive oxygen species and blunt the innate immune response and the associated cytokine storm, allowing for the proliferation of cells responsible for adaptive immunity. None of those things can happen when cells are under a high redox state, and so allowing them to use ketones should help them to call on the adaptive immunity to destroy the virus. What other solutions do we have? NAD and NMN. NAD was originally discovered in 1906. It's able to prevent pellagra, which is a disease of NAD deficiency, and it's vitamin B3 is the name, as you know. NAD has been used for via IV as long ago as 1961. It is critical in mitochondrial function as far as the CERT genes are involved, and as far as producing energy, ATP. It's involved in the in every cell's ability to generate energy, and it's in its cellular sensing of energy production. There are several NAD consuming enzymes. SERCHWINs are one. DNA repair, which is these PARPs, the poly-ADP ribose polymerase. These two actually decrease with aging. However, so you would think that NAD would go up, but CD38, which is an NADase, it directly consumes NAD, increases with age, and it contributes to the decline of NAD with age predominantly. Again, a picture of as CD38 or this NADase increases, you get a decrease in NAD and a loss of mitochondrial function over time. Nicotinamide mononucleotide and nicotinamide riboside. These intermediates have been known present in food for a long time. These NAD levels decline with age and are associated with the development of many age-associated pathologies. Systemic NMN administration can enhance NAD biosynthesis in pancreas, liver, fat, heart, multiple tissues. Intraperitoneal NMN administration can increase NAD levels in the brain. It bypasses the blood-brain barrier. It is safe and well tolerated and does not cause any toxic effects in mice. Oral administration will increase in adipose tissue NAD biosynthesis, and it can normalize adiponectinemia. So if you have patients who you see who have that severe adiponectin deficiency that's typically caused by glucose binding to those sulfa sites, the cysteine sites, not allowing this adiponectin to join into a triplicate so it can be released from the cell, you can use NAD to restore that hypoadiponectinemia and increase the fat burning signal that it goes along with adiponectin. It's associated to improve mitochondrial function, increase oxidative phosphorylation, increase whole body weight expenditure, and thereby improve weight loss. It can improve cognition and memory. It can rescue neurons from cell death. It can restore retinal degeneration. It's associated with age-related loss of neural stem cells because of its effect on senescent cells. It can inhibit acute renal injury, heart failure, and radiation-induced DNA damage. Dosing is rapidly absorbed orally, and it's converted to NAD in peripheral organs. Interperitoneally would be used for neurologic disorders. Do be cautious because NAD metabolism is also how senescent cells how they function, and so you may be stimulating your senescent cells by starting with NAD. This is not where I would start to improve tissue senescence. In a study of 11 men using IV NAD, these are young men, of course, young healthy men. None of them experienced adverse events, but they did have improvement in GGT, LD, and AST, suggesting an improvement in a study of 11 men using IV NAD. These are young men, of course, young healthy men. None of them experienced adverse events, but they did have improvement in GGT, LD, and AST, suggesting an improvement in. I personally really like the sub-Q or oral versions. Growth hormone. There is significant evidence that a decline in circulating growth hormone coincides with the onset of thymic atrophy. And so we know that growth hormone and IGF-1 stimulate thymopoiesis. It's growth hormone induced high insulin, however, is undesirable. And so several authors are out studying the effects, Fahey et al., studying the effects of using metformin, or at present they're using liraglutide to counteract that growth hormone-induced hyperinsulinemia. But we do know that that the thymic epithelia express growth hormone receptors and secrete growth hormone themselves in a positive feedback loop. So it is involved in some way in this immunosenescence. Increased growth hormone acts in the thymus to increase T cell proliferation. It stimulates immunoglobulin production by B cells and increases B cell differentiation. Growth hormone stimulates oxygen radical reduction, so reactive oxygen species, in monocytes and neutrophils. And loss of growth hormone is involved in increased inflammation in the intestines. We know that that low IGF-1 is associated with higher mortality in older humans. In this Fahey study, as I mentioned, a cocktail of growth hormone, metformin, and DHEA were used to restore the atrophied thymus, and it was demonstrated in 4 separate measurements of epigenetic age that this improved lifespan by about 2 years. I think I might have more slides about that. The downside of growth hormone therapy is the cost. FDA prescribing guidelines, the bleed in and the downregulation of receptors. Not bleed like bleeding, but bleed like growth hormone bleed, where it downregulates receptors all over the body. There is some risk of proposed risk of cancer, but I monitor their IGF-1 BP binding protein 3 levels. This binding protein 3 has been associated with improved or decreased cancer risk. We believe that this binds up the IGF-1, excess IGF-1, preventing that risk. There is a downside of abuse, flushing, hypersensitivity, and production of antibodies. That's spelled incorrectly. Sorry. These are some of the available growth hormone releasing hormones, which is my preference to use, as opposed to using growth hormone, both because of expense and because of safety. CJC, tesamorelin, or sermorelin. And then the ghrelin agonists, I use those in combination because they also work to increase growth hormone. And these are ipamorelin. The others are less well available, although you can get MK677 in some places. Regarding senescence, systemic administration of growth hormone releasing hormone does not raise growth hormone or IGF-1, but it has direct effects on the immune system in proliferation and regulation, and on the reproductive system in differentiation. We know that cells from women receiving hormone replacement therapy secrete more growth hormone releasing hormone than cells from women not on hormone replacement therapy. And so we believe that decreased growth hormone and IGF-1 expression can lead to impaired T cell proliferation and immune deficiency. Within the heart, growth hormone releasing hormone agonists can activate cardiac repair. This can suppress tumor growth in human experimental lung and other cancers, again, against that cancer concern. Sermorelin itself stimulates the pituitary gene transcription of the growth hormone messenger RNA. And this is the first to fail. The neuroendocrine axis, the first to fail in aging. A dose of sermorelin would be this. You can use it with berberine for longer. I really like tesamorelin or CJC ipamorelin. Senescence solutions. You can use a fisetin, you can use quercetin dasatinib, and you can use rapamycin. Fisetin is a polyphenol. These senescent cells will upregulate their anti-apoptosis phenotype in order to avoid their own destruction. So drugs designed to treat this anti-apoptotic phenotype are things like dasatinib and quercetin. They are fairly strong direct inhibitors of senescent cells, and they will get rid of a good number, including the necessary healthy senescent cells. Quercetin is a flavonoid with antioxidant and anti-inflammatory benefits, but it is a CD38 inhibitor, which targets that PI3K-AKT pathway. Dasatinib is a tyrosine kinase inhibitor. It is currently FDA approved for treating CML, and lots of places will, lots of research has been done showing that with the two of them showing inducing apoptosis in senescent but not non-senescent cells. Unfortunately, it does this to a great degree and not to a Goldilocks degree. This is where it works here at the AKT-PI3K level, and you can see down here where rapamycin, much like AMPK, blocks that mTOR signal. A current human trial with idiopathic pulmonary fibrosis, taking dasatinib and quercetin on this intermittent schedule. 14 patients showed greater than 5% improvement in mobility, which is not typically seen in pulmonary fibrosis. A second human trial, these are patients with diabetic kidney disease receiving it daily on this on this intermittent schedule. They showed decrease in adipose tissue macrophage accumulation. So cells have improved stem cell ability and reduced senescence associated secretory phenotype. So hopefully, or presumably indicating decrease in senescence of cells in these diabetic kidney disease. Dasatinib is fraught with side effects. You effectively feel like you've had the flu for the short period of time that you're on it. So if you can take the time off to do that, this is an option for you. It does have several medication interactions, so just be aware of these. And Cipro is one of those. Quercetin has a few side effects, and given IV can have some kidney disease. I would not use it in pregnancy or breastfeeding, but fairly mild effects. This is what the standard dosing that we see in the comparable to the human and mouse dosing that they're getting right now. And intermittent dosing is recommended, not long-term, not repeated many times over a year. But it's effective as long as 21 days. Rapalogs, one of my favorite, initially discovered as an antifungal metabolite. It is a macrolide like an antibiotic. However, it's used currently for kidney transplant or organ transplant patients. It has immunosuppressive and anti-proliferative properties, and it specifically inhibits mTOR complex 1. It and its other similar rapalogs are one of the most potent and best studied inhibitors of mTOR. They slow that GERO conversion, that conversion of that senescent cell from a cell that is able to go back into apoptosis or into autophagy into a senescent cell, a permanently senescent cell. Excuse me. It's been predicted that rapamycin would slow aging in mammals, and the numbers of studies have been done since 2009. Rapamycin does prevent this geoconversion to this irreversible senescent cell, and helps with the cell preserving its proliferative potential. Not taking rapamycin may be as dangerous as smoking. Simply not smoking prolongs life by 6 to 10 years. But in just 3 months in middle-aged mice, high-dose rapamycin increased life expectancy up to 60%. When taken late in life, it increases lifespan 9 to 14%, despite a suboptimal dosage. And this equates to more than 7 years of life. So by comparison, smokers who quit late in life gain only 1 to 3 years. It strongly inhibits mTOR C1 at any age and extends lifespan whether started early or late. It is an FDA-approved drug. The common dosing is 2 to 6 milligrams, 1 to 4 times a week, depending on the degree of autophagy that your cell may need. There are almost no side effects at these low doses. However, there are several as your dose increases. Thymosins, thymosin alpha 1. These are bioidentical hormones that are made in the thymus gland. I'm sorry, not hormones, but signaling factors that are made in the thymus gland. They work both on stem cells to improve natural killer cytotoxic CD4 helper cells and B cells, attacking tumor cells and virally infected cells, both directly and indirectly by their mechanism on the progenitor cells themselves, the T and B cells themselves. It is a widely used immunopotentiator. It is an immunomodulator, so it does not suppress or upregulate immune. It is an immune modulator. It works by modulating innate immune receptors, and it inhibits the reactive state of microglia in only 3 days. It improves the levels of TNF alpha, IL-1 beta, and IL-6, which are pro-inflammatory mediators. These are significantly decreased versus saline-treated group. It stimulates T cell differentiation. It enhances Treg. It restrains that auto-amplification of autoinflammation. It increases natural killer cell maturation and activity. It stimulates the production of anti-inflammatory cytokines. It increases the ability of neutrophils to travel. If you remember, we talked about earlier, immunosenescence is involved in decreasing the ability of those cells to travel. Thymosin alpha-1 improves that ability. It promotes that Th1, Th2 shift, decreasing inflammation and increasing the ability to fight intracellular infections. It's involved in increasing antioxidants, including glutathione, and blocks the steroid-induced apoptosis of those thymic cells. Dosage is given here. It's it's been studied down to age 13 months and up to age 112. As you see, 13 months and up to 101. Patients even studied in patients with decompensated liver disease and renal disease. Thymosin beta-4 is another bioidentical peptide produced by the thymus gland. It suppresses the production of pro-inflammatory cytokines. It upregulates hepatocyte growth factor. It is antimicrobial, anti-inflammatory, and anti-apoptotic. It increases those oxidative enzymes, so it sounds very familiar to thymosin alpha-1, to protect cells from oxidative damage. The dosing is here. Max per week is 8 milligrams. If I'm just treating someone for senescence, I'm going to start them with that 100 micrograms once a day. If I'm treating them for a disease state, I'm going to use a lower dose. You're going to be cautious in patients who have, a higher dose. You're going to be cautious in patients who have open growth plates. And I use this typically 6 weeks on and 6 weeks off. I believe there's a reason why God gave us 40 days or 6 weeks. And so I use most things 6 weeks on and 6 weeks off. Mitochondrial-derived peptides such as humanin, MATA-C, and SS31, we want to be cautious about these. They can exacerbate the senescence-associated secretory phenotype if used first. So I'll do a lot of immune modulating before I'll add on mitochondrial-derived peptides. FOXO4-DRI, this is an interesting molecule, a great study out of the journal Cell that selectively induces apoptosis of senescent cells by its modulation of p53, and it changes chemotoxicity and aging in mice. This is affected by the FOXO4 is a effector molecule in IGF-1 production. It works PI3K and AKT modify its ability, as you see, where PI3K and AKT in this example are sending DAF16 into the cell to replicate genes for transcribe rather genes for stress resistance and longevity. And then senescence inducing insulin resistance increases FOXO4 messenger RNA expression, and then p53 controls this apoptosis and senescence, and then MDM2 blocks p53, which is controlled by FOXO4. We can D-retroinverse this form. So FOXO4, we add the D-retroinversion so that this cell can stay around for longer. This peptide rather can stay around for longer. It competes with endogenous FOXO4 for the p53 binding site and then disrupts the senescence-associated nuclear exclusion of active p53. In this mouse study, you can see the mouse that was treated with FOXO4 RI has this lovely black coat. The mouse not treated has this advanced aging and frailty. And this was, again, a mouse study. There are no human trials. In vivo, it's been given IV. And then this is the dose that's given, a human equivalent dose. I'm having trouble finding this anywhere right now. So this is my senescence solution summary slide. Step 1, clear the senescent cell burden, improve the immunosenescence, and then step 2 is upregulating the cell's ability to handle its cellular stress. Oxidative stress is the main concern. I did not include ketone esters, but I would certainly include ketone esters in step 1 in this scenario. Rapamycin at these doses, thymosin alpha. You might use quercetin, or if you're interested in using that, foxo4 and can find it. That is a way. I typically will use rapamycin, TA1, TB4 in my step 1. I'll do this for 6 weeks, and then I'll add in, presuming the patient's feeling well, I'll add in either NMN oral or NAD, either sub-Q or IV, and one of the growth hormone, releasing hormone, and ghrelin agonists. Then I might add on a mitochondrial peptide, rotate these around. Of course, what I would continue my thymus gland peptides, as they have been so helpful with immunosenescence. And so I thank you very much. This is how you can reach me, and this is my YouTube channel in case you're interested in more information. But thank you very much.